This is the halftime show. I'm Bad Bunny. I'm joined by Pedro Pascal and Lady Gaga. So thank you for joining us for the halftime show. This is our bodega.
Well, I can't really beat that intro, but I'll give you the facts, which I don't think Jonah did. So welcome back from the break. I'm very pleased to introduce our panel. It will be moderated by Nikita Singareddi, who is the CEO of Fortuna Health, and she is also the Berkeley Public Health Impact Fellow who helped plan this hackathon. Joining her are Nate Favini of Pair Team and Jonah Frohlich of Manatt Health, and they will join in a discussion about Medicaid innovation. So Nikita, take it away.
Thanks, everyone, and thanks, Nate and Jonah, for joining me for the halftime show. So we are the Beyonce of, whatever is in between, but I don't think we can beat the pitches that, just happened. So just give a quick round of applause for the teams who really over the last 48 hours, as Grace and Claudia mentioned, have done such a fantastic job. And I think partially to complement some of the pitches that we saw, speaking and hearing from two folks that have both been some of the folks that have crafted and implemented policies and been both on the private sector side actually executing in a lot of ways against those policies. I want to start with a question that relates back to the Medicaid Innovation Challenge that you hosted, Nate, when you were a Impact Fellow last year. There were a number of different proposals and entrepreneurial ideas that were related to 1115 waivers like CalAIM. There were folks that had ideas related to the justice involved in reentry populations. Jonah, you've led at DHCS, part of the policy side of this as well. When a new policy like HR 1 happens at the federal level, and you have a private sector organization, a startup, and you have the state that's executing against existing policies, how do you create organizations that are resilient to keeping the trains on time for the existing policies and then getting ready and bracing for a new policy change?
Great. Jonah Frohlich, I've worked with DHCS. My colleagues here do too. We have for a number of years since CalAIM. Also work with HCI on data exchange framework and some of the other departments in the state. When we're designing programs with our partners in DHCS, they're the driver's seat. They're working and negotiating with CMS every day. And so when we design waivers with them and we're helping to advise them, we have to enter this negotiation and then craft these programs and then support implementation. And it takes years. It literally takes 2+ years to design something like an 1115 waiver and then implement it with, for example, the Biden administration, and then a new administration comes into town, they have some different ideas. And so what it requires is we have an agreement with the federal government for a program like the 1115 waiver called CalAIM, and we're renegotiating it now, but new directives come down. HR 1, the big bill, has a very different set of expectations for states. And so what the state's response is, well, in this case, what HR 1 does is many things, but one of the things it does, other than the Rural Health Transformation Grant, which is fantastic, but one of the things it does is it puts things like work requirements in place. And so that cuts to the heart of like DHCS programs, which is all about like enrolling people low income and keeping them enrolled. So the response really has to be, how do we minimize harm? What do we do to try to identify as many people who can be exempt from the work requirements and who can help them with what's called redetermination? So every 6 months, you have to re-enroll people. So the response becomes, what is our strategy? What's our plan? And tactically, what are we going to do to work with partners like counties, county agencies, our health plan partners, and our provider partners to gather data and to support new processes and new technologies, and then go to the federal government and say, this is how we're doing it, and get approval to make sure that we are in bounds with the new law and with the rules that operate the Medicaid program.
It's a great question, and when you think back to the Medicaid Innovation Competition a year ago, in many ways it feels like we live in a totally different world than we had at the time. And yet, it's one of these things where the more things change, the more they stay the same. Pear Team is a care delivery organization. We're a technology-enabled medical group, and we deliver care using community health workers, nurses, LCSWs, nurse practitioners in the community to high-needs Medi-Cal beneficiaries. And we partner with community-based organizations, social support organizations like shelters and food pantries to meet our patients' social needs, all of this enabled by a technology platform underneath. And because we're a care delivery organization, the point of view I think we just naturally gravitate towards is what do our patients need from us today, and what do they need from us now in the changing policy environment that we're in. And so when HR 1 passed over the summer, we very quickly started saying, okay, how do we build out the infrastructure to help our patients navigate these new community engagement requirements that are going to exist? How do we leverage our community-based partners to get people into volunteering opportunities or work opportunities or job training programs that will help them meet those community engagement requirements? And we also started to say, this is not something that just our high needs beneficiaries are going to need help with, right? Like today, we primarily work in CalAIM in the Enhanced Care Management Program, which is really focused on the 5 to maybe 10% of Medi-Cal beneficiaries who are highest need from a medical and social point of view. But suddenly, this has always been true, but even more so now, everyone in Medi-Cal is going to need the type of navigation support that we provide to clear these hurdles and maintain their enrollment. And so we've started saying, how can we use technology in even more innovative ways, leverage AI, build agents that help people navigate these types of challenges, so that imagine if everyone could have their own personalized AI agent that helped them navigate these challenges. That would be a very different world than one where the very limited supply of community health workers that we have in the state is required to get everyone through these types of requirements.
Jonah, this question is for you. And if you don't mind, I would love if you could put both your former state hat on and your Manatt hat on for this. Do you mind sharing with the audience a little bit about what states are actively doing in their implementation right now? How are they going through the process component and the implementation component? How are they working with their stakeholders? And how are they introducing technology or adapting existing technology?
I worked in the Schwartz administration for about 2 years, and then I've been at Manatt for about 15, so I have a little experience working both in state government and outside of it. So states, honestly, when HR 1 passed, kind of freaked out. Like they completely flipped. Because it essentially said within 2 years, you have to do things that states haven't been able to do in decades. They said you have to integrate all these systems across like health and social service programs. And these, if you think about Medi-Cal, it's a $200 billion program. It's as big as Ford Motor Company. And then you've got the Department of Public Health, and you've got the Department of Social Services, and you've got counties that operate massive systems that are essentially like different industries, and you're telling them in 2 years you have to exchange data between them. These are multi-billion-dollar organizations. So they flipped out because it's an impossible task that they were given. So one of the things that we have done with our partners in Medi-Cal, the Department of Healthcare Services, which if anyone's looking for a job there, HCI, you should go, because it's really friggin' cool, is they're like, we have to find a way to get as much data as we can about our members to help exempt them from work requirements. And there's things called medical frailty exemptions. So with these medical frailty exemptions, what it says is if you have a medical condition that legitimately allows you to say you can't work and meet those community requirements, then you do not have to go through a process of this like redetermination of every 6 months having to go back and demonstrate that you are able to work in the environment. So we went through this whole process of identifying what are the clinical factors, the diagnoses that somebody would have that would demonstrate that they have a clinical condition that designates them as medically frail. And so we worked together and we identified with our clinical partners and consultants what were the diagnosis codes, and then we went deep into the data to look at who in Medi-Cal qualifies for these things. And we've actually had some really good results, but we want to go further. We want to go into the community. We want to partner with health plans, with Manifest MedX and other information exchanges to acquire data from hospitals, from health plans, from providers about Medi-Cal members to be, what have we missed? Who got admitted in the last month because they have end-stage renal disease or cancer or something else that should rule them out, but we don't have claims for them. So we are now working through a process of, can we get that system, the data from those systems, into ours, incorporated into the data environment at DHCS, and improve the number and grow the number of people who we can exempt from this process and allow them to continue to be on Medicaid. The biggest challenge Medi-Cal has is reaching 15 million people every 6 months. Many are homeless. Some people churn. They're low-income people. Some of them are incredibly difficult to reach. Every 6 months to get them to re-enroll in the program. So part of our job is how do we acquire the data? How do we make sure we can negotiate with CMS to say these are legitimate? So it's a huge operation, and the reason why I say DHCS is a great place is because they have leaders there right now that are phenomenal. They work harder than, I've been in a startup, I've been in a .com. They work harder than I did when we were in a .com era. They're incredibly dedicated to this, and it's just a great environment.
Yeah, Jonah, you really highlighted the scale, the sheer number of folks that will need to be redetermined every 6 months and have, depending on who you are, might have work requirements and community engagement as well. When you think about scale versus trust, Nate, in the work that you've done as a physician, but also leading an organization like Pear Team, how do you balance those elements of the things that are scalable are, technology related, that can reach people but may not get into the nuanced elements of each person, each household, and then knowing the cost associated with trying to do things with a very, heavy touch. How do you balance those things at Pear Team?
We wrestle with this every day. We have in enhanced care management, we have a very human intervention that requires building trust between our patients and our community health workers, but our nurses, our LCSWs, our nurse practitioners, and you have to hire the right people to fill those roles. You have to give them the time and the space to build relationships with the patients that we serve, and we know that. And at the same time, we look every day, and there are 750,000 people who are eligible for enhanced care management in California, only a fraction of whom are currently receiving the service, and we feel this imperative to push and reach more people. And there is a constant tension between how quickly can we grow this thing and serve more people before we start breaking the metrics like trust and retention in the program, and our community health workers' speed of learning. And so you have to look at, we look at metrics like how our patients score our team on things like trust, on retention, how the rate at which we retain our patients. And then you introduce AI as an additional layer on top of this, and you have an entire new layer of questions about trust. How do people interact with AI? And I will say, we started doing calls between our AI agents and patients, and we had no idea what to expect. We really started out with the hypothesis of probably we'll get some engagement. Probably some people will really like it, and probably some people will totally hate this. And that has basically proven to be true. But the first call I ever listened to between an AI agent and a patient lasted over an hour. And this was a patient who was homeless, sleeping in her car, was looking for help navigating her housing, ended up telling her entire life story to our AI agent, who we call Flora. And we gathered so much more history in that visit than we ever would have if we had put a community health worker against that visit, because our community health workers don't have an hour to stay on the phone with someone on the first call. And we were blown away by the potential of this technology, but it raises all kinds of questions too, right? About how are you using it, the governance, is it going to prove to be useful for people over the longer term? Is it dangerous in some ways, and how do you build the right guardrails into that? And so these are questions that we're constantly wrestling with. And I can't say we've landed the answer on all of them, But we have metrics internally that we follow, like the retention of our patients, like their engagement with us, that help, and literally what they tell us about how they feel about us and our intervention, that help us sort of track how we're doing on that.
I like that you called your AI Flora. We call ours Felicia, but that's a working name. We might change it. Speaking of AI, Jonah, what is the perspective that states have right now viewing AI, particularly within the HR1 context and the rural health context? Are they seeing it as a boon, something helpful to them? Are they scared? What's the state perspective?
I think they're very curious. Looking for practical applications for AI, the first immediate practical application is analysis. There's data analytics and applying AI agents to be able to better assess the data that they have, because, I mean, truthfully, state agencies are data rich and pretty information poor. There's not nearly the kind of robust analytics that you might expect from an organization that runs like a $200 billion enterprise. As you would expect. So I think they could really leverage the data that they have, and apply analytics and deep machine learning to better understand what information they actually have. Things we saw, and my colleague Laura and I were at a conference about a year ago, the MESC. It's like this IT conference for Medicaid geeks.
The Super Bowl for Medicaid.
It absolutely
keep
is.
the analogy
That's where
going.
I saw Bad Money. And that's where we started to see last year what was happening in state government with AI, and it's very preliminary. There's not a lot happening yet, and they're starting to deploy bots and AI agents just for frontline customer service, and overseen with actual human agents. So it's very early, but there are companies that are starting to invest. I think IBM and others, and doing basically a bunch of skunk works in a couple of states, trying to test out, like, what can we do? How can we apply AI in this context? So there's a lot of curiosity. We have not seen a lot of real movement yet in the application of AI in Medicaid agencies. I do think in the next couple of years we will. We are starting to see interest in how we govern this. Like, when we apply AI to our systems and our data, like, how do we make sure we have a governance process to make sure we have privacy and security? If we're using technology, what do we do around our data assets? So there are a lot of questions that they have about how do we do AI in our systems in a way that's helpful and sustainable. So a lot of curiosity, but not yet much movement.
Interesting. On a slightly different topic for you, Nate, what are the things as a provider and an implementer that if you could go talk to the state, whether it's HHS or DHCS or even, let's say, CMS, what would you tell them as a provider group to say, hey, these are the one or two things that are really, really important that you think about and get right so that we can be successful in supporting you on your policy initiatives and objectives?
We have spent a lot of time doing both of those things, both in Sacramento and in Washington, D.C. I think it's okay for me to share with all of you. The California Healthcare Foundation has put together a Future of Medi-Cal commission that Mark Galley, the former Secretary of Health, is chairing. And we're writing one of the bold idea papers for that commission, and I'm pretty sure it's not like under any binding agreement. But regardless, the core notion that we're advocating for, and we're talking about this outside of the paper too, is agentic infrastructure at the state level that would allow AI agents. You as an individual could authorize your AI agent to access your data that is in a bunch of different places all over the state and counties around California, and that if there were a centralized consent mediation function, that you could give your consent and allow that agent to access data from all of these different systems. And then that agent would be able to do really useful things for you, right? Like, it could identify if there are benefits that you're eligible for that you're not receiving today. It could identify proactively that, like, maybe because you've missed a few utilities bills, there's a rent support benefit that through Medi-Cal that you might not even be aware exists, and we could match you to that, and then your agent could actually figure out how to help you get it through your Medi-Cal plan. And so the idea is there's this notion in the world of agentic infrastructure called model context protocols. We use MCPs in healthcare to talk about the managed care plans. It's also MCPs, but the idea is it's a set of tools that agents can use to gather information and to do things in the real world, and that states, governments should think about how do we surface all of this information that we have via model context protocols to agents that can do really useful things for beneficiaries with that information. And then the second thing that we've really been advocating for in Washington, D.C., and actually have made a ton of progress on over the past year, is that you need AI native payment models. Because you can't, if you try to pay for this stuff on a fee-for-service basis, there's no way it will work because there's no human doing a thing, which is the usual trigger for payment. And you certainly do not want to pay for an AI doing a thing, because that will just go like this as soon as you start paying for it, because the AI will just do millions and millions of those things and get paid for them. And so you need value-based payment models to do this. And you specifically want the pricing of these models to be deflationary. You want to price them at a very low price that actually makes it so that you have to use AI to do this and not put human labor resources against it, because it's impractical and it won't scale to everyone. And CMMI actually launched a model in December called the Access Model, all caps. We spent a bunch of the last year with them thinking about, us and a bunch of other people, thinking about what that model could look like. And we are very excited about this model because it's priced at a very low rate. Your payments are outcome dependent, not just activity dependent. And we think that if you were able to push the access model, this type of payment model, out into managed care through Medicare Advantage and into state Medicaid programs and managed Medicaid, that it could actually become the payment infrastructure for these agentic actions that we're talking about that the state could enable on the other end. So this is the thing we've been spending a lot of time with folks in Sacramento and DC about, and I would love to talk. I could talk about this forever. Would love to talk more with folks about it if it's interesting.
I think that seeing in both of your different answers data and having access to data came up, whether it was data between organizations or consent-based data. Could this be Medicaid's interoperability moment? It seems still shocking to me that.
Yes.
Yes. All right. Amazing. You've heard it here first from Bad Bunny that it's going to happen.
That's right. July 1st. We'll come back. It's going to happen.
Exactly. Maybe to wrap this up before Conclave comes back, deciding who the next pope is. I've heard a number of people, whether it's folks that are on the state side or even companies, say that HR1 in a lot of ways is a crisis opportunity. So when you think about the consequences of HR1, the one big bill, what unintended consequences do you think may happen, both positive and negative?
I mean, I don't know. This is not an unintended this is an intended consequences of people in Washington. But there was a report that came out of the California Behavioral Health Directors Association that basically said there will be billions of dollars in new, essentially uncovered costs that counties are going to have to pay for people who are newly uninsured. So, and there's no budget for that. Our state is in essentially a fiscal crisis. You don't hear about it a lot. But we're going to be billions of dollars short for potentially 1.5 million people who might fall off rolls that we cannot get, that we can't get them redetermined, we can't get them exempted. So a very real, I believe, intentional output from this federal legislation is get people off of Medicaid, and the impact is going to be on states to cover the costs of people who no longer have coverage, and there's no federal funding for those people. It's all going to hit the state. So it's going to hit everybody in California who lives here. It's going to hit everybody in every state where there has been any kind of Medicaid expansion. And it's just an unfortunate consequence, which is why we're doing all this work to try to keep as many people covered.
I think this is both an unintended and an intended consequence, what I'm about to talk about. I think it was unintended by the legislature when they passed HR1, but now intended by CMS as they are implementing it. I think this may be the moment where our healthcare system shifts to an AI-driven system, and it's because you have both like really very real constraints on cost being imposed on the system, whether it's the Medicaid cuts or the fact that like they have this CMS has really constrained Medicare spending as well. They're not increasing Medicare Advantage rates anywhere close to what the industry had anticipated. And so you're seeing them signal like, hey, the brakes are on spending. We are cutting back dramatically. And if you talk to folks there like Chris Klump, who runs Medicare, he sees this as like a generation, like a civilizational level crisis, the amount that our country spends on healthcare for the results that we get. And they see their role as like, we are the ones pulling the brake. And they know there are going to be a bunch of consequences to that, but they are very purposefully making that decision. And I think that the potential upside of that is if we can use this moment to really jump onto the AI rails, we can do better care at a lower cost. And that's the imperative for all of us who work in this industry, is to figure out how we can do that with the constrained resources that we have. Don't let this be that everyone in the train falls over. Figure out how to make this switch and really continue to support the people that we all care about.
Thank you so much, Nate, and thank you so much, Jonah, for sharing your perspectives and also stressing the pragmatics of what's going on and the moral imperatives that we have as people building, whether it's companies or crafting policy, working in the space. Really appreciate your thoughts. Thanks, guys.
Thank you.
Nikita.